Hello, everyone. I'm Dr. Christopher Bundy. I'm the Executive Medical Director of the Washington Physicians Health Program, and this is your May 8th Washington Medical Commission Lunch and Learn. And it's always a privilege to be here as a guest of the commission to spend a little bit of time talking about what the program that you select to be your therapeutic alternative to discipline in Washington State, how we're functioning, what we're doing. We believe that this accountability and transparency to what we do is really important to the work. We also want to give you all an opportunity to interact with us as we've gotten into the virtual world and the hybrid meetings, the opportunities to connect and share about our work, both from the regulatory side and from the therapeutic side, have diminished a bit. So this is a really nice opportunity that we have to interact with you and tell you a little bit about our program. Our mission in the 40 years that we've been in Washington State doing this work is to remain. We believe that we are a trusted resource. We want to remain a trusted resource for restoring the health of medical professionals, providing confidential support that leads to exceptional outcomes and reassurance of safety to practice, thereby supporting and sustaining our workforce in Washington State. And that ultimately advances the health and well-being of the medical community at large. We know that approximately, just epidemiologically, if you look at national studies, and we believe that doctors are no different than anybody else with regard to prevalence of mental health, substance use disorders, and other health conditions that can impair safe practice. We believe about a third of us will have an impairing health condition at some point in our career. That doesn't mean we're all going to be impaired. Illness is not impairment. Lots of us are getting help and getting support for the health problems that we have, and we'll never need the support of WPHP. But about 1 to 2%, we estimate, of practicing health professionals are impaired in a given year and may need more support, the kind of support that WPHP can offer, particularly when that illness is starting to impact function and safe practice. There is a legal requirement in Washington State. Washington is among probably 2/3 of states that have mandated reporting obligations for concerns of impairment. All DOH license holders, health systems, employers of physicians, professional liability carriers. There's a whole kind of list of individuals who are mandated reporters of concerns of impairment in Washington State. You can actually fulfill that requirement as long as there's been no patient harm by contacting WPHP in lieu of making a report to the department or the regulator. There's statutory immunity for people who make a good faith report to WPHP, and WPHP itself has immunity as long as we carry out our duties in good faith. Our model is voluntary, confidential, and therapeutic. Some people wonder about that voluntariness of WPHP. Are they truly voluntary? And I'll show you some data in a little bit that we kind of think differently about voluntary self-referral versus other types of voluntary referral. The only, for the purposes of kind of your understanding and how we classify cases, the only cases that we consider non-voluntary are those that are mandated by you to come to WPHP. So but I would say even philosophically speaking, an individual who chooses to work with WPHP in order to satisfy the requirements of a regulator is also making a voluntary choice. Medicine is, after all, a choice. We use accountability to promote safety and earned advocacy. And a lot of the folks that are coming to us, something has happened where a question as to their safety to practice has been raised. There's concerns, and they often need a third party to be advocating for them, credibly verifying their safety to return to practice, but keeping that all within the confidential bubble so that the employer or the credentialing entity doesn't have need to know the specifics of diagnosis or other protected health information. That privacy and that confidentiality then encourages early reporting. When people feel that they can be helped confidentially and that it won't negatively impact their reputation or their career, they're more likely to seek help than otherwise. And obviously, we make a notification to the regulator when indicated if patient safety cannot be maintained or if an individual is not following program requirements to the extent that we feel that we can't credibly endorse that they are safe to practice. And those are all laid out in statute. This process diagram Wouldn't be a presentation if we didn't have a QR code. We've got a few of them in this deck. So, and I believe Amelia has access to this as well. One of the things I would really encourage you all, just in terms of your own learning about WPHP, is to go to our website. We took about a year to develop this process tool. You can actually click through this. This is an interactive tool that we developed to really make the process as transparent as possible so that people can understand what's going to happen at each step of the way with the WPHP process. And you can see one of the couple things I would highlight about this diagram. One is WPHP provides certain services, but we also use qualified evaluators and treatment providers to provide other services. For example, we don't diagnose and treat. So if we can't clear somebody, if somebody's referred to us and we can't quickly sort of determine through our process, which includes an extensive health questionnaire, toxicology testing, Columbia Suicide Risk Assessment, Montreal Cognitive Assessment, and a 2 to 3 hour biopsychosocial interview, if we can't rule out impairment based on that data set, then they're going to need some type of additional outside evaluation, independent medical examination, fitness for duty evaluation by an outside provider. And it's actually a part of our DOH contract that WPHP has to utilize evaluators and treatment providers that we have deemed qualified to be able to provide this service to safety-sensitive workers. It's very hard to just go down the street to ABC Mental Health and get a fitness for duty evaluation. A lot of folks that are great mental health providers have no idea how to do a fitness for duty assessment. So that's just an example of some of the things that we are needing to look for when we are approving our evaluation treatment providers. At each step in the process, there's an off-ramp. There's an off-ramp back to advocacy. There's an off-ramp back to work if the individual has had to stop working as a result of a health condition. Not everybody goes from referral into a health support agreement, aka monitoring. So, and we see, and everybody's case is a little bit different, and and people off-ramp at different parts of this process, which I'll show a little bit more about later. Or now. So many cases are resolved actually with help and reassurance. Most people who are coming in, they need something. They need some type of support, and so we are able to provide that. There's not a lot of folks that don't need anything from us. Last year, of the 132 that were referred, we assessed 73%. That's a little bit low, and I'm not sure, it's a bit of an anomaly. We usually assess about 85% of referrals. So that meant that there were quite a few referrals that came our way that there just wasn't enough information for us to act on. Sometimes those are anonymous referrals that we get where we don't even know the name of the clinician, but they're calling us about somebody that they're worried about. They want to talk about it, and they don't get fully processed through the system. But last year, about half, and this is pretty normal, about half of individuals that got referred to us ultimately ended up in a health support agreement. So off-ramping at those different parts of the process, with about half getting to that end point of needing continued health support and advocacy. Last year, usually runs 55 to 65% of referrals today are for non-substance related concerns. So people often think that physician health programs primarily are dealing with substance use disorder, and that was probably true in the early days, but for at least the last 10 to 15 years, we crossed a threshold where we now get more non-substance related referrals. Now, some portion of those will become substance referrals when we get into the details of why they refer, but they might have been referred as a quote unquote distressed or disruptive doc, and about 12% of those referrals end up converting over to some other diagnosis, typically substance use disorder. So there's some change in terms of how things shake out. So the referral reasons broke down a little bit. That's an odd look at that graph. So last year, about 44% of that 56% that were non-substance, 33% were psychiatric, 9% medical, and that number's increasing as we're seeing an aging of the physician population. We're seeing more physicians being referred for senior career cognitive issues or health conditions. Chronic illness burden can negatively impact overall in terms of medications, and number of diagnoses can actually correlate to work performance issues, and then problematic workplace behavior, quote unquote disruptive doc, et cetera. Some of this downward trend in program utilization is artifactual of the fact that we've just been clearing people, old people out of the system that weren't truly active within the system. But last year, you can see that we had, at the end of the year, at the end of 2025, we had a total of 242 active cases. 215 of those were in monitoring agreements. We had a total of 60 admissions last year, which is pretty on par. I mean, the year before we had 81, which was a big year for admissions to the program. So you can think about referrals, and that number might go up or down, but are we kind of admitting the same number of people to the program year over year? And that's been pretty consistent over the last 5 years. So this is, I'm sorry, I don't know why the graphic is displaying in this way. While most of our referrals are not for substance use disorder, when we look at who's in monitoring agreements, the majority, 60%, are substance use disorder monitoring agreements, or what we call health support agreements. That's a lot of that's because our substance use disorder agreements are 5 years. So just the length of time will increase the prevalence. If you think about your public health or statistics training, prevalence of an illness is increased by the duration or chronicity of that illness. So thought of in terms of what we do, the longer the agreement. The other agreement types, the psychiatric monitoring agreements or the medical agreements, the SUD1 is a 1-year monitoring agreement for somebody who's diagnosed with a mild substance use disorder. Moderate to severe substance use disorders are the 5-year substance use disorder agreements. So you can kind of just see how it breaks down for the 215 that were in an agreement last year. We don't need to notify the regulator very often about somebody who's in the confidential track. And 85 to 90% of program participants, and this is important because in Washington, this is a little bit different. I'm going to show you some national data later that will underscore this, but we're proud of the fact that most people in our state are not coming from or discipline involved. In many states, most of the participants in the PHP have come through the disciplinary process, and that's flipped. So in some states, it might be 90% of the participants are involved in discipline that are in the PHP, and only 10% or so are coming in unknown to the disciplining authority. So very different. Yeah, and I should have another slide that shows where they come from, but largely employers, credentialing entities. I'll show you that in just a second. Probably, I would say Minnesota, especially states where the PHP, even though it's confidential, is also part of the board. So Minnesota, Texas, Iowa would be examples. So we also like the fact that we don't have to let you know very often about somebody where it's not working out. But we do. You'll get referrals from us from time to time of an individual that we haven't been able to find a path forward with. Last year, that was 11% of cases in development. Now, historically, that's been under 5%. So last year was a little bit of an anomaly in terms of numbers of folks that we sent your way, and I'll show you some more of that data too. And then participants who have progressed all the way into a health support agreement, those referrals are typically people who are failing out of their health support agreement. They're not able to maintain compliance with the program, or despite compliance with the program, their illness is such that they're just not safe to practice, and we can't continue to maintain them within the confidential auspices of the program. And last year, 87% of WPHP participants were in the program and never known to you all. We report to you, there's a few different statutes that delineate what the trigger is for reporting. In some statutes, it calls for clear and present danger. Other statutes require non-adherence with the program requirements or assessment that we're unable to determine what the risk is. Substantive non-adherence with this health support agreement, danger to the public is basically if we see that an individual, if we can't manage foreseeable risk with an individual who we're working with, you're going to get a notification. Oftentimes that individual's not continuing in the program. They've either decided during the development phase before a health support agreement that they don't want to participate in our process. They don't like what it is that we're recommending, and so they say, I'm not going to work with you. And we say, well, based on what we know at this point, we can't let you just go off and do your own thing. Our mandatory reporting requirement has been triggered, and nobody comes into our program not knowing. We actually have 2 points at which we do a fairly involved informed consent process that explain, and that's actually required in statute. We have to tell people that one of the potential consequences of not working with us is that they might be notified to you all. So they know coming in the door that that's before they give us any information about what's going on, that a possible outcome is that we would have to notify you if we have concerns about their safety to practice, and that we're not able to mitigate that through participation in our program, including oftentimes cease practice during a time of evaluation and rehabilitation. Last year, we had 28 individuals overall in all disciplines that we serve. MDs, DOs, physician assistants, podiatric physicians, veterinarians, and dentists are the groups that we serve. And of those 17, we're under order by you all to be participating in WPHP. And as I said, we had a fairly high number of regulator reports in 2025, most of those coming to you guys. 14 of the 18 notifications that we met came to you all. Sorry about that. Is a WPHP, is a individual in a health support agreement, are they a safe clinician? I think the answer has been yes for many years. There are several studies that support this, but why? Being in a health support agreement, we hold people's feet to the fire to get treatment that we know that works for their condition. So not only have they been rehabilitated and deemed safe to practice, but we keep them in treatment that is also known to improve long-term outcomes. Risk of impairment should illness recur. We have a lot of data that's coming in about these individuals. We have a workplace liaison. We have toxicology testing if indicated. They're meeting with their case managers on a regular basis. They're meeting with their health providers who are providing us with quarterly reports. So we have a lot of data sources that are looking at the individuals so that if they are getting sick again, we can intervene before they are actually putting patients at risk. You have the reassurance with somebody who's in WPHP, a hospital, a health system also has the reassurance that that individual is known and is being watched in the way that we've suggested, compared to the universe of unknown folks, of which some proportion of those individuals are posing a risk to patient safety right now today as we're speaking. Why 5? We often get the question, why 5 years for a monitoring agreement? There's actually 3 studies that have looked at this. High quality studies that have looked at what's the risk of return to use for somebody who's maintained abstinence for 3 to 5 years. And that risk is approximately equal to the population risk of developing a new onset substance use disorder. So we think that by the time we've gotten somebody to 5 years of monitored abstinence, their risk of return to use at that point is approximately equal to the general population risk of developing a substance use disorder in the following year. Does that make sense? So they've kind of been returned, if you will, to baseline risk for developing recurrence of the illness. Yes, that's right. Perfect. We also have some studies. Actually, WPHP did a study that was never published with physicians insurance years ago, because physicians insurance used to surcharge people, add to their premium if they were involved with WPHP. And Lynn Hankus, former medical director at WPHP, who some of you know, Dr. Domino did a paper with Dr. Hankus looking at risk factors for relapse in folks in WPHP. It's probably one of the most cited papers in the physician health literature, actually. But Dr. Hankus went to physicians insurance, had a conversation with the new CEO there, Mary Lou Mizrahi. He said, I bet my docs are safer than the average bear. And Mary Lou said, I'll take that bet. And they looked at claims data for WPHP participants versus folks not in WPHP, and found that WPHP folks were in fact safer than the general population of folks that hadn't been in WPHP, and they eliminated that premium ad for those folks, but we never published the data. But Colorado Physicians Health Program in 2013 did the same study and published the data. And what they found is that people who graduated from the PHP had a 20% lower likelihood of having a malpractice claim filed against them than never participants in the Colorado Physician Health Program. So a few data points, a little bit out there, that suggests that individuals who have been through our programs have a lower risk. In terms of program outcomes that might be of interest to you, we loaded your packet. There's a lot of materials on our website. We're very interested in measuring outcomes, evaluating what we do, how it's going. 87% confidential participation, as I mentioned, almost 90% reported needing and benefiting from the advocacy that we provide. They come in, they're in some sort of elevated temperature water. We get them out of that elevated temperature water, get them back to work, and advocate for them. We advocate for them with you all. We advocate for them with the DEA, with their attorneys. We advocate for them in legal processes. We advocate for them with their employer. We advocate for them in credentialing. The list goes on and on. This is a lot of the work that we do that goes on behind the scenes that people don't see, but our program participants really appreciate it. 85% say the program was at least helpful or extremely helpful or life-saving. Almost 80% would refer a colleague if they had a concern. 71% in full remission at discharge, which for mental health and substance use issues, to have full remission of disease, these are unparalleled outcomes. 98% are at least improved, meaning in full or partial remission at the time of discharge. It's almost 100% improvement. 85% with substance use disorder are abstinent at discharge 60 months. If you're a housed, employed individual in the general population, your risk of relapse after an index episode of treatment is about 30 to 50% in 6 months. So again, superior outcomes with regard to substance use disorders. That's 2.5 to 3 times, just if you want to hang on to a number, better outcomes in the PHP versus what somebody would expect in usual care. 48% of our program participants currently report that the program was life-saving. And I'm going to show you some suicide data in just a second. I try to add a little bit extra, a couple special topics for you all. Since you indulge me to be here every year, I try to give you a little bit more each time I come of a little different slant or take on things. So I'm going to talk about suicide. I'm going to talk about the the FSPHP national data, which is not been published. We have 3 manuscripts in process for that, so you're getting like a special early peek at the data. We measure burnout amongst our program participants similar to the way that it's measured in national samples, the Shanafelt data, and we do comparisons. So year over year, you can see that we have less than half the rate of burnout in program participants. I just like to highlight that this one data point really shows that the benefits of program participation extend beyond just the impairing health condition. We measure a lot of things I'm not going to show you today, like quality of life, improvement in relationships, et cetera, et cetera, et cetera. So burnout, people are enjoying their work more, they're enjoying their lives more. They really had a transformation as a result of coming into the program. At exit, overall, how helpful was the work, was the experience? You can see the data here. Very helpful, life-saving. We want to see these rightward shifts. We know that some people are not going to be happy with the program. I like to say that we're similar to a chronic pain clinic. If you have too many happy customers, you're probably not doing something right. So we are going to have some happy customers, unhappy customers. I like the unhappy customers over on the far left to be around 10% or less. I mean, we don't want to be deaf to our critics either. And we get a lot of write-in responses, which are really interesting and fun to read sometimes. From the Yelp effect kind of program naysayers that have lots of things to say, but not always constructive. They don't always actually help us improve the program. But we definitely like to hear from participants about how we can make the program better, how we can decrease burden, how the program can feel more just to them. At exit, 90% often or always report being treated with courtesy and respect. How would you rate the value of advocacy? I already talked about that. I talked about refer a colleague. This is stakeholders. So you presumably might have gotten this survey. You should. I hope you're getting the survey link. I hope you're filling it out. We can break it down by its hospital CMOs, its regulators, its evaluation and treatment providers. It's a whole host. Really, everybody in our database gets a chance to fill out our stakeholder survey. It's not just our participants. And, again, I think fairly strong support from the healthcare community overall that WPHP is effective in restoring the health of our participants. In terms of just kind of last year, what else was going on within WPHP that we were kind of trying to manage and what we were struggling with. Clinical staffing and complexity. So we have not been fully staffed since the pandemic. We've been understaffed by usually 2 clinical coordinators, which is tough in an organization that only has 20 staff overall. So that's been a challenge, as has been the increasing clinical complexity of the cases that we're seeing. So we're seeing lower numbers of referrals. We're seeing people coming in later, but with more problems. And one of the proxies for that, I would say, is the number. Remember those data I showed you about how many regulatory referrals we made last year? That's a complex case for us. So anybody who's getting referred to you all is a complex case. So I see increases in regulatory referrals as a proxy for increasing case complexity among the individuals that are getting referred to us. Colorado published a paper at the end of last year demonstrating over 10 years an increase in case complexity in their program. And I think that this is a national phenomenon. This is what physician health programs are talking about nationally, is that the cases are getting more complex. What does that mean for us? Yes, yes, yes. Yeah, all of that, all of it. So it's medical, it's multiple medical conditions. It's the need for doing neurocognitive assessment, which is, that's a whole talk about, how do you get good neurocognitive assessment in the community that's tuned to fitness and of safety sensitive workers. That adds complexity. I think dealing with, we have a fairly algorithmic clinical pathway for substance use disorder, whereas when it's not substance and it's a host of other concerns, including personality, layered onto what we call classically Axis 1 disorders, mood, anxiety, trauma, all of that coming together, making the cases more complex. I think the legal environment, I don't know if Scott has any thoughts about this, but the joke now is doctor plus chat GPT equals litigation and attorney. So we see a lot of we're seeing in the PHP world an increase in overall litigation. I guess I'll use that as my segue. I was asked to comment briefly on the litigation that we're currently experiencing. This will actually be part of my 2026 annual report. Earlier this year, we were named in a class action lawsuit with 2 residents from the University of Washington who were terminated from their positions. I can't comment on the specifics of that lawsuit. All I can tell you is it's in the public domain. We think that the allegations are unmerited. We plan to vigorously defend ourselves against what we think are unmerited and false allegations in the report, and I wish I could comment further on pending litigation. Obviously, I have a lot to say probably about it, but we're going to leave that to the appropriate legal channels. But I think it's worthwhile for you to be aware, for you to also be aware that it's caught some attention in the social media. It's been picked up by legacy media as well. So if you're hearing about it, if you need to talk about it with us, please give us a call. We have a whole, we can talk to you and we can take those questions for you if that's not something that you're comfortable answering. So we're happy to, if you want to refer those to us or refer those to WPHP, you can certainly do that. We're prepared to answer those questions. I'm getting ahead of myself here. Part of the answer to the increasing complexity and difficulty recruiting highly skilled clinicians, which also, by the way, adds cost. All of our clinical coordinators are licensed at the master's level, ideally dually licensed in both mental health and have a substance use disorder professional license. Can't always get that. We've made some adjustments to our compensation practices in order to try to be more effective in recruiting highly qualified, highly experienced individuals to do this work. But when we can't do that, we've pivoted a little bit to building out a quality assurance team. That team now has 4 individuals, and really a lot of what they do is offload administrative burden so that our clinicians can be maximally effective at the top of their license. And I think that's been a real success for our program, actually. We have been really at the forefront nationally on toxicology testing. We've piloted several iterations of this over the years and continued to innovate around DNA-based self-collect technologies that allow people to not have to go to a collection site and urinate in front of an observer. It's more dignified, it's faster, it's less burdensome. So we're constantly thinking about how to manage the burden of the program, the cost of the program against the integrity of having a high quality testing system. We have, fortunately, in light of what's transpired in the last few months, spent the last couple of years also building out a robust communications team. Vanessa Bloy, who's probably on the call, but I can't see. Nadine Rossetti is her supervisor. She's our administrative director, but Vanessa is our communications manager. Allison Yang is my assistant, but also our communications team assistant. These folks are working very hard to get a message out about WPHP, to raise awareness about WPHP. Some of the things that we hear from the community is that people just don't know who we are and what we do. So we're trying to change that and be more effective in terms of making sure that those who need to know about WPHP. But as was discussed earlier, we also live in a world now of mis and disinformation. I was listening to a Hidden Brain podcast on my way here today about radical acceptance, which is a principle that I'm very much a supporter of from the perspective of being a psychiatrist. And radical acceptance is accepting the world as it is, not as we would like it to be. And certainly this legal case and the PR around it has given me an education in the world as it is versus the world as I would like it to be. And fortunately, we took measures a couple of years ago to be prepared for just this type of situation. We think that the best way to combat mis and disinformation is not to engage with it, but to simply do the best that we can to tell the story as we see it, as accurately and truthfully as we can, and hope that people will have the information that they need to make good decisions for themselves. My biggest concern around the mis and disinformation, reputational harm to the organization is an issue. But what's more concerning to me is that vulnerable individuals who need help will be discouraged, will be frightened, and bad things will happen to them in terms of their own life, in terms of their own safety, in terms of their career, because they listened to a message that was not accurate and really was discouraging and increased their hopelessness. So that's why we are really serious about this work and getting the right messages out there. System redesign efforts include our toxicology testing system, include our clinical data information systems. We're in the process of vetting some alternatives that are just coming online using agentic AI development tools that we hope may lead us to better programs and actually programs that can predict individuals within our monitoring programs that may be at more risk. It's one thing to track the compliance data. It's another thing to be able to then look at that compliance data and say, does this tell us something about risk in a way that can help us intervene more proactively rather than reactively to problems? So that's another issue. And then we have really been doing a lot of advocacy around licensing and credentialing reform. That work we've done locally. We were instrumental. We really led the effort to have the Washington practitioner application modified it for, again, now it is in compliance. It is now out in the CAQH portal for credentialers in Washington. So we're very excited about that change because the Washington practitioner application is the most widely used credentialing applications for hospitals and health systems in the state. There's still a lot of work to do. We've done that credentialing reform with physicians insurance. We've done we did it with you guys many years ago. You really led the world in credentialing reform back in 2017, before it was hip and cool, before the FSMB ever wrote anything about it. You'd already made the changes. So we're just really proud of that work. And frankly, it's been this body's work in that area, even in 2022, going to an attestation model. That's been something that's been really helpful for me to hold up in my advocacy work as an example for others to follow. So thank you for that. Thank you for that partnership. There's a lot of other things that we've done in terms of advocacy. We show up in Olympia to testify on behalf of bills that you guys run that support what we do. So the anesthesia associate bill We testified for that. There was a relinquishment bill that you all ran that we testified for. So we work collaboratively with you on the issues that are important to the commission and to us. A whole bunch of things you can go on our website. We've really worked very hard to build out the resources that are available on our website. We have a newsletter that comes out quarterly that we get actually pretty positive feedback. Nobody wants more stuff in their inbox, but we get a lot of positive feedback about our newsletter. It's a nicely curated bit of stuff about not only what's going on at WPHP, but kind of like what's happening in physician health and well-being, keeping you up to date and up to speed. So I encourage you to check out all those resources. We also recorded this video, which is just under an hour. It will soon be, we've been approved for CME credit for it. You can click on it. You'll be able to get CME credit by watching it. Your hospitals and healthcare institutions can use this for training about impairment. It can be built into a process. We're actually involved with a new project, a new initiative that we're tentatively calling Project Hope TM, Health Organization Partner Engagement, where we're engaging with health systems to develop clear policies and procedures for how you deal with impairment, how you educate your staff around impairment, a whole host of tools and toolkits, how to have a conversation with somebody when you're concerned that they might be impaired. So if you or your institution is wanting to have that kind of engagement with us, it's a 4 to 6 month engagement. We have a whole kind of agenda for how that goes, setting goals. What is it that you want to accomplish? A lot of institutions are saying, what can we do? What can we do for physician well-being in our institution? And a lot of well-being committees have reached out to me and said, we're not making a lot of progress, or our committee isn't being well supported. We've tried some things, but we're not sure what to do. And my answer is, well, let's focus on impairment. Let's focus on mental health. Let's focus on part of the problem that we can get our arms around. Because my experience even today is that a lot of health systems don't really still know how to do this very well in terms of identifying and addressing impairment. And we want to partner to build that into an infrastructure so that it can be handled a little bit more effectively before things get to the point where they can no longer be ignored and are coming in hot and complex and more likely to have regulatory involvement. Yes?
I was just wondering if I can ask you.
Yeah.
Wonder, as you have focused on so many years of successes about helping those individuals who have impairment of any sort, I'm sure that you have identified aspects of your program that really would help anybody without an impairment. So do you have any thoughts about a program, kind of like a program like the Beaver, that is just available, optional to anybody without having to identify themselves as having an impairment or burnout or any other problem? And it's kind of like the difference between going to the hospital or urgent care when you have something wrong with you versus going to the gym, which is, from a healthcare perspective, we really, also from this perspective, is there like a version of just going to the gym for this issue?
It's a great question. There's a lot of people and institutions that have come into this space.
Before you get into that,
yeah.
I'm just thinking like, as you pointed out, those individuals who go through your program, they have lower liability risk. They have safety records that are better than the general nation of physicians. It's almost like, well, why not just apply that to everybody, right? That could be a business model where there's a financial benefit, maybe perhaps even a patient benefit, to having physicians opt into this.
I agree. So Jason Siegel, he's a PhD psychologist out of Claremont University, Graduate University, partners with Greg Gouldner from HCA. Greg was formerly the vice president for graduate medical education. HCA is one of the largest health systems in the country. They have more residents than any system in the country. And I work with them on something called the ACGME Affinity Group. And what we're really interested in is not like, what can we build? The question is, if you build it, will they come? And this is really a big issue, is the issue around help seeking and recognizing that you need something, even a WPHP light, and whether it would be used. And a lot of people have tried to enter this space, particularly since the pandemic, and have tried to build things. And you get an initial wave of folks that are really the true believers, who want and need these kind of services, recognize it, and invest their personal time. But when you take busy health professionals who often have difficulty acknowledging that they might need help and offer them a service, oftentimes they don't utilize it. So it's a tricky problem, and I don't have a really good answer to it. Part of me believes that in a perfect world where people would utilize something like that, we might cease to exist. Like there might be this, it's a little bit idealistic, because I think that we deal with real illnesses that no matter, how many bench presses you do or pull-ups, you're still going to get depressed and suicidal because you have a bad illness. And there's always going to be a need for us to be there when things get tough like that. I think we could spend like the afternoon almost looking at this problem of what services can be offered at what level and what intensity that people would accept. I've seen companies like Marvin come in, or Vital Work Life as an alternative to EAPs within health systems. They're subscription model based. They offer a suite of coaching and counseling services, light. They also offer concierge services, get your dry cleaning done, cracked windshield repair. The data is still mixed on utilization. Hospitals and health systems are spending big dollars to buy these subscriptions, to have a service and a resource there for their medical staff, and it's not clear to me that it's being well utilized at this point.
I can imagine that if there was some kind of a program that could be put together, not for people, again, who have identified issues, but just, the preventative care type of model. And if a liability or a malpractice carrier might say, hey, you do this program from, with Chris Bundy, we'll lower your rates by 5% or 10%. I mean, that could be a good, monetary incentive to do the program. And then hospitals might even actually endorse that for their, hospital list.
You can think that there's, we get into some big brother questions here, but there are also, models that have been discussed where the chief wellness officer isn't the cheerleader for well-being within the organization, that there are actually variables that you could measure, including like wearable technology and other things that would be proxies or indicators of the well-being of your staff, and you could incentivize people in various ways to wellness in just the way that you describe. And you can imagine that there are people who really embrace that idea, and then there are people who really are allergic to that idea as it being sort of invasive and intrusive. So I don't know what the answers are, but I'm definitely in that space of, how do we help more people earlier on? But how do we help doctors understand the professional responsibility that they have? How do we help doctors understand that health is intimately tied to professionalism? I mean, it's laid out in the AMA Code of Ethics that we are responsible for our professional well-being, because it's long been recognized that health connects to care quality and care safety. We are the instrument of healing, and we have to care for that instrument. And I don't think that message gets indoctrinated into us in a way that or maybe even supported. We do a lot of mixed messaging as we bring people, medical students and residents through. We teach them to be unwell. You know, we give lip service to wellness, but we don't really create systems in which it's always possible for them to attend to their well-being. So those confusing mixed messages say, yeah, take care of yourself. But at the end of the day, what we want from you is performance and excellence. So do whatever it takes to get to that. Yeah, yeah.
Let's go. But have a CME, um, physician wellness boot camp. 1 week, you know, we have boot camps of everything now, right?
Yeah.
Why not a physician wellness boot camp where you get 40 hours of category 1 CME and you pay for it or your health system pays for it, and plus or minus your healthcare premiums go down 5%. But at least you have a voluntary system where people will say, you know what, this looks really interesting. I'll go do it. I'll go spend, you know, a week up in the mountains with Chris Bundy and his crew and a staff of well-trained people and just see what you got going. This looks really interesting. And I'll get 40 CME hours.
Yeah. I think if we threw in farm to table, cuisine, and massages, we would get some good uptake on that. I hear you. We actually, you know, 10 years ago, we had a partnership with Mindfulness Northwest, and we were doing mindfulness-based stress reduction through WPHP. And, you know, it was a journey because we did Chris Bundy Light through Mindfulness Northwest. And again, we had people, we would fill every class for about a year and a half. We filled every registration. People came and they did mindfulness training and mindfulness-based compassion, and then registrations just dried up. So we had this pent-up demand that we satisfied, and then we couldn't sustain it. We couldn't get more people coming through. So we eventually abandoned it. We still partner with Mindfulness Northwest. We still promote the work that they do because we believe in them. I did a 5-day silent meditation retreat with them last summer. It was great. But, you know, so it's, yes, but I don't know if that's our mission at WPHP or somebody else's mission to do that. And if you do it, I will come. You build it, I will come. Yes, Ms. Blake. Right, right, correct. So what you're talking about, the way I conceptualize it, you know, we used to talk about burnout, we used to talk about personal resilience. Now I just think of individual factors and system factors. And what you're describing, we don't want to forget about system factors. For a while, we couldn't even talk about individual factors. It became verboten. It was all about system factors for probably the last 7 or 8 years, because we were talking initially in the physician well-being space only about individual factors, personal resilience, et cetera. That felt like victim blaming, right? And it was to a certain extent. But the reality is that it's all of those things. Personal resilience is still important. Individual factors are still important. WPHP lives in the individual factors space. But we certainly partner with organizations to think about system drivers as well. And they often ask us what we think about system drivers. So it can be both and, but you're absolutely right. I mean, those are real challenges. Talking about radical acceptance. We have to radically accept that this is the reality in which we are operating. Doesn't mean that we endorse that reality, but we accept it for what it is, because we can't get to solutions until we acknowledge that what you're saying happens is absolutely what's happening in the world. I'm going to show you this video. This is our brand video. We just developed it this year. What do you think? Vanessa Bloy, who's on the call, was the mastermind for this video. It's nice to have some of the folks that we work with talking about what we do. It's one thing for me to get up here and do my song and dance, but I'm biased. But it's nice to also hear some of the other voices of people who have been positively impacted by the work that we do, and our communications team has been wonderful. I see questions popping up on the screen, so I want to give the folks that are remote a chance to ask questions.
Hi, this is Ziad Al-Sufi. I have a question about, first, it's a very nice program. Thank you for the video and the presentation. I'm just wondering, like, how can we, like, when I'm working, can we use this program? And we have things that are similar, like we have programs that are similar, we have coaching, we have when someone have an issue. I was just wondering, how would that work, and how can we coordinate things like that? And would that be helpful for me to take, or doctors in this commission to talk to their hospital that they work with, or that's not how this should be used?
Yeah, I think it's a great question. Any hospital or health system is going to be dealing with, concerns, trying to support their staff. They're going to see things. They're going to wonder, well, where's the right point at which maybe utilizing WPHP, because we provide a unique service. I would say first and foremost, don't ever hesitate to just call. It's not about just when to make a referral, but it's also like, use this as a consultant. We're a resource that exists for you in your healthcare ecosystem. And I would say, when a performance issue, I would say, first of all, health doesn't show up as health symptoms. Depression doesn't show up as depression in a healthcare professional in the work environment. Depression shows up as charting delinquencies, unreliability, mistakes and errors. So it's performance-related problems. And when you're getting to that point where, you've had the cup of coffee discussion, you've tried some normal kind of coaching and feedback around concerns, when those things aren't working, and before you're going on a path to progressive remediation, where there might be adverse professional consequences for that individual, that's a great time to call us and say, this is what we're seeing. Do you think you all could be helpful? What else might be helpful? Do you have ideas about resources that we could be utilizing? We think that this individual needs a coach. Do you have somebody that you could recommend based on what we're seeing? We want to be that to you. We're also happy to talk with you about not a particular individual. I always think proactively engaging institution to institution. So who are the decision makers? Who are the leaders within your healthcare organization? And how can we connect with them and talk more about what we do? We have model policy for referral and consultation with WPHP. We have a lot of tools that we're willing to share out to sort of help an organization mature its ability to think about and deal with these problems, so that the intervention, if you will, or what the system is doing around a doctor who might be in difficulty is calibrated and tuned to the circumstances. Does that answer your question, Dr. El-Soufi? It's nice to meet you, by the way, virtually. I hope to meet you sometime in real life.
Nice to meet you too. Yes, it does answer my question. Thank you so much.
Was there another question from the virtual audience? I know we have 4 minutes, so I want to get through these special topics. I think they're relatively quick. Some of the narrative that you see out there that I think is very irresponsible is how suicide is discussed. There are guidelines. American Foundation for Suicide Prevention, the American Society for Suicidology, others have recommendations about how we communicate and talk about suicide. One of the things that we don't do when we talk about suicide is we don't sensationalize it, and we don't blame. Those are very dangerous ways of communicating, and they add harm. The ways that we talk about suicide in the media can actually cause a contagion effect, where individuals are more likely to end their life. And there's data that has shown that strings of suicides can follow on media coverage of a suicide event, for example, high profile, that sort of thing. So we have to be really careful about how we're thinking about and how we're talking about these things. And one of the messages that's been out there for a while, I didn't invent it, is maybe referring somebody to the physician health program will cause them to kill themselves, or maybe physician health programs and the stresses of physician health programs cause people to kill themselves. First of all, suicide is a very complex, multifactorial event. It is tragic every time it occurs. 90% of people who end their lives have serious mental health issues at the time of death. So to point the finger at any one institution or event as being causative, I believe, and Christine Moutier, who's the CMO of the American Foundation for Suicide Prevention, she and I have worked together on a lot of projects. I know her thinking about this aligns to mine. We also have a physician suicide expert on our board of directors, Dr. Jeff Sung. He and I did an article for the Medical Commission a few years back about this very issue. So we take this really seriously. But we said, well, what can we learn? What can we positively do about this to kind of look at our own practice? And what we've done is we've looked at our annual survey, and we've added some questions around this, as well as our exit survey, to assess suicidal thinking, behavior in program participants, and how that might change during the time of their participation in WPHP. Our process is pretty robust. All new referrals, as I mentioned, are screened with the Columbia Suicide Risk Assessment. At first contact, even before we do formal screening, we ask everyone, are you having thoughts of hopelessness or ending your life? If we get a positive screen, we do a comprehensive suicide risk assessment, which is gold standard in mental health. Our interventions include safety planning, transition to definitive care when needed, safety planning, including identifying key supports, assessing and mitigating access to lethal means, all the high impact interventions, and then building a caring connection as quickly as possible. When people feel cared about, it really decreases their risk. Ongoing assessment until risk returns to baseline. Reassessment if we get a sense that somebody is distressed and might need to be reassessed. We have a variety of tools and policies that we've built out that we use as a program to make sure that we're doing top-notch work in this. I came to WPHP from VA Puget Sound, where I was the chief of mental health and chief of psychiatry. And if you know anything about the VA, you know that the VA takes suicide prevention very seriously. So I came out of a culture where veteran suicide was top of mind. And I brought those skills and tools that I learned through the DoD and through my work at the VA to the work that we do at WPHP. This is stunning. So in our annual survey, 41% of individuals reported, and this is all years of involvement in the program, but they report that in the year prior to, recollecting on the year prior to coming in to WPHP, 41% of individuals reported feeling hopeless or suicidal. That's about 6 or 8% of the general population feels that way at any given time. So you're seeing a pretty elevated risk just based on thinking. In the year prior to WPHP, I attempted to end my life. 6% of individuals reported attempting to end their life prior to coming in. It's pretty high. Now, what about when people leave the program? So at program exit, you can see, and this is the leftward shift that we want to see. Far left-hand column is people who said not applicable. I've never been suicidal. But for the rest of folks, 56% of folks had fully resolved feelings of hopelessness, suicidal ideation, or suicidal behavior. And 92% were resolved or improved. I think that this is pretty good indication that WPHP is addressing suicide risk and bringing it down. So while it's understandable that people would imagine, and a professional identity threat has been linked to increased suicide risk in healthcare professionals. So we know that people who are coming in, who have been referred by their employer, where an issue has come up, a concern, that's impugning their professional reputation. We know that these folks are at that point are at high risk. So we're very attuned to this, but we're also know that the answer, if you have chest pain, is to go to the ER, not to avoid the ER. We're the same thing, and we're not going to save everybody, but the folks need to come. They need to get assessed. They need to start getting plugged into the services that we know are going to decrease their risk. That's my pitch on that. And again, participation in WPHP has been life-saving, and I've heard enough of these stories over the years to know that these people mean it when they report it this way. It's not hyperbole. They're not being dramatic. I'm just going to quickly run you through the Federation of State Physician Health Programs National Survey, just because I want you to have a point of comparison about kind of where WPHP sits. This was 51 state voting members of the Federation between August of 23 and September of 24. We had a 94% program response rate, so 48 out of 51 programs participated. I'm only going to show you some aggregate data. We had a lot of qualitative write-in responses that you won't really see here. The national data reveal a few things. One, that PHPs have an important role in supporting clinician access to mental health services and protecting patient safety, that we provide an array of services across the United States, including WPHP, and that special confidentiality is afforded through these programs, and that there's opportunities to continue to raise awareness and strengthen collaborations between PHPs and health systems, some of the stuff that we've been talking about, some of the work that we're doing currently. So this is just the conditions that PHPs monitor. So 100% monitor substance use disorders, but 96% monitor non-substance related psychiatric conditions, behavioral concerns, suicidal ideation, and so on. So scope of practice is bigger than just substance use disorders, as I mentioned, and that's pretty consistent nationally. For substance use disorder cases, how does confidentiality look? And you can see that initial contact and the time of entering into a health support agreement. And during that health support agreement, over 90% of programs are able to keep those individuals confidential from a regulator. And even half of programs can keep them confidential from the regulator, even if there are non-compliance issues. And I would say that's true for Washington. We're only going to notify you if somebody is a danger. We're not going to notify you if somebody has a positive test. We know how to evaluate a positive test. We know how to manage a positive test. We know to evaluate whether that's returned to use. We know how to intervene appropriately to keep people safe. So we're able to keep people confidential. So we're in that half of folks. And the same thing is true for mental health cases. Same numbers exactly. I think I talked about this. We're in the far right-hand column. We have about a $3.5 to $4 million operating budget, which allows us to be a leader amongst physician health programs nationally. But most PHPs are probably underfunded for mission. And when you hear about some of the struggles of physician health programs nationally, I often think that this is connected to the fact that these programs need greater support. I don't know that if everybody knows that I'm also the Chief Medical Officer of the Federation of State Physician Health Programs and the past president. So I'm connected to this larger national work and what's going on with our partner programs. In our state, as I mentioned, we about 10 to 15% of referrals in a given year from the regulator, but in other states, it's a larger proportion. So on average, 35 to 40% of referrals are coming from the regulator. I think that's a good thing. I think it's a good thing that we don't have as high a percentage, because it means we have a higher percentage of non-regulatory action coming in. You send what you need to send. I think you guys make great choices about what you send, but it just means that we have a larger percentage of non-regulatory involved, which is what we want. We want people to trust and use us upstream of regulatory involvement. This is new referrals nationally, and before this data came out, before we did this study, we couldn't tell you how many physicians in the United States were being helped by PHPs. So really kind of foundational data. So over 3,500 new referrals in the reporting year, and of those, you can see how they progressed through. 83% had a formal evaluation, like one of those evaluations where they got referred out of the PHP for some independent medical examination, fitness for duty. 81% of those were recommended for monitoring, so overall 67%. So about half of individuals in our program compared to about 2/3 of individuals nationally getting into monitoring agreements. And again, I think that reflects the mix of sort of quote unquote voluntary or confidential participants versus regulatory involved participants, and the prior test probability, if you will, that somebody is going to need to be monitored coming through. So overall, we think that about 10,000 physicians are served annually through physician health programs. I don't know any other system that's providing this level of service to this many physicians. And this is just physicians. You can see, I'll hopefully show you in a minute, that most programs serve other profession types like we do in Washington. So just of interest, what do physicians with substance use disorders, what are they using? Probably not a big surprise that a lot of alcohol, opiates come in number 2, but look at number 3, polysubstance. Polysubstance is the norm, not the exception. So it's, really for folks with substance use disorder, this is what we're seeing. A lot of stimulants and prescribed stimulants. There's a recent study out, 85,000 patients from Norvalco at NIDA. The rate of stimulant prescribing over the last few years has really gone up. And we're seeing a lot more medical students and residents getting adult diagnosed with ADHD. This is a whole problem. Maybe next year I'll talk about this problem that we're seeing, because we often undiagnose that problem. Putting people on stimulants who don't belong on them is not a good idea. This is also, I think, interesting. We get a lot of think a lot about depression as a health condition. We think about depression and suicide in physicians, but similar to the general population, for those of you who have some experience in mental health, anxiety disorders are the most prevalent mental health conditions in the general population, and it's true for physicians as well. And that's important because being anxious and being depressed in terms of help-seeking behavior, in terms of how you hear information, it's different. So if we have to know, like, what are people coming in for? And anxiety disorders, we have a lot of anxiety in healthcare professionals. Some of that anxiety is probably functional. Some of that anxiety is probably connected to our tendency to be compulsive and detail-oriented. So it's, there's a point at which healthy anxiety improves performance, and then there's a point at which it becomes unhealthy and you see performance decline. Trauma is a huge issue. A lot of us are drawn to the profession because of the trauma that we experienced prior to coming into the profession. People with big brains that can do lots of things, why do they choose to be healers? That's a whole other topic we could get into. But physicians that we see score high on adverse childhood experiences scales. So trauma and so our care needs to be trauma informed when we're working with these populations, which is a whole other topic. We actually have a trauma informed care expert coming to our annual reunion this year to talk about that. Another mythology is that we don't allow people to be on medications for opiate use disorder. This data shows clearly that the vast majority of programs do permit people to be on medications for opiate use disorder, including agonist medications, while practicing. But before we had this data, we couldn't definitively say that was true. There was an article in the New England Journal in 2019. It was an opinion piece. It said there's a blanket ban on use of medications for opiate use disorder. We were actually the earliest adopters of medications for opiate use disorder because we were trying to put anesthesiologists back in the OR. So we needed a way to treat them that was going to be reliable, that was going to protect them against overdose and diversion. So I would argue that we probably have a higher penetration of MOUD in physicians' populations. And the problem is not that physicians are clamoring for medications for opiate use disorder. Like any patient, we have to convince them to take it, and we have to convince them to stay on it, like any other psychiatric medication. So just some data now that we have that can help us have more reasonable conversations about what it is that we're doing. These are the study contributors. We contributed data analytics to this effort from WPHP. That, my friends, is the end. I'm sorry I went a little bit over. Lots to talk about. Happy to take any questions. Always grateful for our relationship and the support that you provide.